Hi everybody, here we are again. We're delighted to be back talking on our final session about motivational interviewing. I know that there's people sort of gradually joining us. So first of all, thank you for being here for this course of webinars. We're really delighted that this has proved to be so popular and that the participants yourselves are interested and are coming back each week. So we are extremely grateful and very impressed by everybody's dedication to this series. So thank you. And of course, we have Igor with us again, who's been fantastic in the sessions so far. Just a little update in case anybody is new about ISSUP, the International Society of Substance Use Professionals. We are a membership organisation for anybody working in this field. We have around 11.5, well, over now, about 11,750 members working across the full spectrum of people that are working within prevention, treatment, recovery care, volunteers, professionals. You know, we like to bring everybody together from around the world. We deliver our work in 3 ways. So we have a digital channel, which is our website, our newsletter. You're all on one of our online events. We have national chapters, which is where we have in-country organisations that are delivering the mission of ISSUP, and events. So at different times, we've obviously had face-to-face events, but we're really delighted about how well we can still have these connections and these training and professional development opportunities with people in an online capacity. So I will hand over now to Igor, who, as you all know, is an addiction psychiatrist, who at present is Professor of Psychiatry at the University of California, San Diego School of Medicine, and the Director of the UCSD Addiction Training Center, Director of the SAMHSA International Addiction Technology Transfer Center in the Ukraine, and co-director of the SAMHSA International Addiction Technology Transfer Center in Southeast Asia. Thanks again, Igor, for joining us today. If any of you listening have questions, we're going to give some time at the end, so you can pop those in the questions box and we will come to those at the end. So over to you, Igor. Thank you.
Thank you. Okay, folks, good morning, good afternoon, good evening, whatever time zone you're at, I don't know. This is our last session on this subject. We have quite a lot of things to do in a limited time, so let's try to get to work right away. Yesterday we stopped at the talking about the issue of change talk and sustained talk. Let me just remind you, the change talk and sustained talk are 2 different types of statements that are always present. Change talk is something that the clients say in favor of possible movement toward change, and the sustained talk is everything that the people say in favor of not changing anything, keep it as is. And the 2 types of statements are always present, but they're present in different proportions. It could be very little change talk and a lot of sustained talk, and there could be a lot of change talk right away if you're lucky, but some sustained talk as well. And this is what makes the motivational interviewing a directive style. This is our clinical skill to separately hear and differentiate, distinguish change talk from sustained talk. Because what we want to do, we want to reinforce the change talk, to assist the client to talk more about the change, because we know it from both science and clinical experience. This will automatically make the change more likely. And you don't want to reinforce the sustained talk, everything that the person says in favor of not changing anything. This is a clinical skill that we will try to practice today. Here is what we will do first. I want to show you a video. Hopefully you will be able to see it the way it is, depending on your the Wi-Fi speed. I hope you will be able to see it. We will watch 2 videos. Let's start with the first one, and then I will tell you what are we going to do with that.
As this provider becomes more and more confrontational in her warnings about tobacco use and her advice to quit smoking.
Okay, so I wrote a prescription for an antibiotic for Aiden that should help with the ear infection, but in looking through the chart, I mean, it seems like he's had 6 or 7 of these just in the past year or so. That's really a big problem.
Yeah, it's pretty stressful for both of us. He gets really upset.
Well, one of the primary risk factors for multiple ear infections in kids is actually smoke exposure. Are you smoking?
Yeah, I do smoke, but I don't smoke around him. I try really hard not to smoke around him.
Well, the fact that he's having these ear infections is indicating to me that he is being exposed to smoke. And so, what can you tell me about that?
I don't know. I mean, I try really hard not to smoke around him. I don't smoke in the car. When he's home, I go outside to smoke. I mean, I know it's bad, and I know it's bad for him, so I don't want him to be around it, so I try really hard.
I really need you to quit smoking, both for your health and for Aiden. Did you know smoking around your child is associated not only with ear infections, it could get to the point where you have to put tubes in his ears pretty shortly here, but also things like vitamin C deficiency, cavities, like dental cavities, behavior problems, asthma, other upper respiratory infections. It's really putting him at a lot of risk. In addition to that, kids of smokers end up smoking themselves. Do you want him to grow up to be a smoker?
No, but I don't smoke. I've thought about quitting, but it's really hard. So I just don't know how to do it.
Well, now's the time to quit. It's really gotten to the point where you can't keep smoking. Not only for him, like I said, but also for you. You're putting yourself at risk for lung cancer, for emphysema, for oral cancers, for heart disease, for all kinds of things.
I know. I've heard people have told me before. I've heard all that. I just don't know how to do it. How am I supposed to quit? It's so hard.
Well, there's all kinds of things you can use now. It's not as hard as it used to be. You can use nicotine replacement. There's patches, there's lozenges, there's gum, there's the inhaler, there's nasal spray. We can talk about medications. You can try Chantix, you can try Zyban. There's quit smoking groups you can go to. There's hotlines you can call.
I just don't have time.
There's no reason why you shouldn't be able to quit. This is really important.
I understand that. I know it is. I mean, everybody has problems, right? It's really hard.
Well, what can be more important to you than the health of your child?
I don't know.
Okay, folks, I will stop at this point. And there is nothing much to discuss. This is a horrible interaction between these two people. The doctor is pushing, the doctor is attacking, the doctor doesn't listen at all. The agenda, her agenda, the doctor's agenda is in the middle of the conversation. So there is nothing much to discuss. I think it's obvious to you, to all of you, that this interaction is terrible and it will never result in even quitting smoking idea. Now, I want to see the interaction between these two people on the same subject, but this time the physician is using some skills, some of the skills that we discussed in the previous 3 webinars. Let's watch, and then I will give you an assignment.
As this provider becomes more and more confrontational in her warning needs.
So I wrote a prescription for antibiotics for Aiden. I did want to talk to you, though. I'm a little bit concerned looking through his chart at how many ear infections he's had recently, and I noticed that you had checked the box that someone's smoking in the home. So I was wondering if you can tell me a little more about that.
Well, it's just me and him, and I do smoke. I try really hard not to smoke around him, but I've been smoking for 10 years, except when I was pregnant with him. But it's so stressful being a single mom and having a full-time job, and so that's why I started smoking again.
You have a lot of things going on, and smoking's kind of a way to relax and de-stress.
Yes, yeah. Some people have a glass of wine, I have a cigarette.
Sure. And it sounds like you're trying not to smoke around him. Why'd you make that decision?
I know it's not good for him. I mean, I've read those things about ear infections and asthma and stuff, but other kids have ear infections and their parents don't smoke.
So on the one hand, you're worried about how your smoking might be affecting him, and on the other hand, you're not so sure if it's really the smoking that's causing these problems.
Right. Yeah. I mean, he doesn't have asthma. He hasn't had a lot of other problems that his other friends have. So, and I've thought about quitting before in the past, but I just don't see how it's possible right now.
What made you decide to quit smoking when you were pregnant?
Well, he was inside me, and we were sharing everything, and I knew that he would get some of that, and I just didn't think I could live with myself if something happened to him.
Right now, though, it feels almost too difficult to even manage or even to try.
Yeah, exactly.
How were you successful when you quit before?
I don't know. I think about it now. I don't even know how I did it. I just did it. You know, I just couldn't imagine like him not being born or going into labor early and him having problems and stuff like that, all the stuff that they talk about with women who smoke. So that was just enough to say, okay, you know what, I'm not going to risk that. So
the risks were so scary then that you're able to stop. But
yeah,
they don't feel as scary to you now.
No, I mean, we're two separate people, and like I said, I try really hard not to smoke around him. I'm pretty good about that. I don't let other people smoke around him. So
you're doing the best you can do.
Yes. Yeah.
Okay. But it sounds to me too like part of you really does want to quit.
Yeah, I know that I need to, and I keep every new year I say, okay, this year I'm going to quit smoking, but then something happens and it just doesn't.
It's on your to-do list. It's just not making it to the top.
Yeah.
If you did decide to quit, on a scale of 1 to 10, where 1 is not at all confident, you don't think you could do it, and 10 is you feel pretty certain that you could, where do you think you fall right now?
Probably like a 5, kind of in the unsure area. Like I know I've done it before, so I know I can do it, but at the same time, it just seems really hard, and it's not the same situation.
Well, what made you say 5 rather than 2 or 3?
I know all the ways it's bad for me, and I don't want him to grow up thinking that it's okay to smoke. I don't want him to use any kind of, I don't want him to chew or anything like that. So I know I need to, especially before he gets old enough to understand what mommy's doing, but I just don't know if I can do it.
Okay. So it sounds like you have a lot of reasons why you'd like to quit. You have been successful quitting in the past, and right now you're just feeling a little bit hesitant about your ability to do it.
Yeah.
Where do you think we should go from here?
I don't know. I'd like some help. I just don't know what kind of help I need.
Sure. Well, if you'd be interested, that's something I can definitely talk to you about. There are a lot of new options that can actually help people be way more successful in their attempt at quitting. There's different medications you can try.
I don't like medicine.
Okay. There's also a lot of support groups and classes that you can take where you have other people to go through it with you. And sometimes just having that support can be a big part of it, especially for people like you where smoking is such a stress reliever.
That sounds nice, but I'm not sure if I have the time for all that.
Sure. It feels like something that would take up a lot of time and maybe not fit into your life. I wonder if we could talk about some options that might fit into your life.
That would be really nice.
Okay. Well, if you're willing, then we could set up another appointment where you could come in and we could talk more about.
Okay. Now, I guess you understand that you see that this type of interaction is quite different. They're discussing the same issue, the smoking, but this time the doctor is using some skills. Here's what I want you to do next. I hope you all see me. I don't see you, but you see me because I don't see myself on my computer. Here's what we will do next. We will see this last video again. I want you not to pay any attention to the doctor. Listen only to the mom. Every time you hear change talk, you will give the thumb up. Every time you hear the sustained talk, thumb down. And if this is a neutral talk, meaning neither change nor sustain, just do nothing. Okay? And I will help you with that. This will be, I think, a good exercise in practicing how to differentiate change to how to listen selectively. Okay, let's try.
Antibiotics for Aiden. I did want to talk to you, though. I'm a little bit concerned looking through his chart at how many ear infections he's had recently, and I noticed that you had checked the box that someone's smoking in the home. So I was wondering if you can tell me a little more about that.
Well, it's just me and him, and I do smoke. I try really hard not to smoke around him, but I've been smoking for 10 years, except when I was pregnant with him. But everything is so stressful being a single mom and having a full-time job. And so it's just, that's why I started smoking again.
You have a lot of things going on, and smoking's kind of a way to relax and de-stress.
Yes. Yeah. Some people have a glass of wine. I have a cigarette.
Sure. And it sounds like you're trying not to smoke around him. Why did you make that decision?
I know.
I hope, folks, you're doing it with me, okay? Let's continue.
Not good for him. I mean, I've read those things about ear infections and asthma and stuff, but other kids have ear infections and their parents don't smoke.
So on the one hand, you're worried about how your smoking might be affecting him, and on the other hand, you're not so sure if it's really the smoking that's causing these problems.
Right. Yeah. I mean, he doesn't have asthma. He hasn't had a lot of other problems that his other friends have. So, and I've thought about quitting before in the past, but I just don't see how it's possible right now.
What made you decide to quit smoking when you were pregnant?
Well, he was inside me and we were sharing everything, and I knew that he would get some of that, and I just didn't think I could live with myself if something happened to him.
Right now, though, it feels almost too difficult to even manage or even to try.
Yeah, exactly.
How were you successful when you quit before?
I don't know. I think about it now. I don't even know how I did it. I just did it. You know, I just couldn't imagine like him not being born or going into labor early and him having problems and stuff like that, all the stuff that they talk about with women who smoke. So that was just enough to say, okay, you know what, I'm not going to risk that. So
the risks were so scary then that you were able to stop. But
yeah,
they don't feel as scary to you now.
No, I mean, we're two separate people, and like I said, I try really hard not to smoke around him. I'm pretty good about that. I don't let other people smoke around him. So
you're doing the best you can do.
Yes.
Yeah. Okay. But it sounds to me too like part of you really does want to quit.
Yeah, I know that I need to, and I keep every new year I say, okay, this year I'm going to quit smoking. But then something happens and it just doesn't.
It's on your to-do list. It's just not making it to the top.
Yeah.
If you did decide to quit, on a scale of 1 to 10, where 1 is not at all confident, you don't think you could do it, and 10 is you feel pretty certain that you could, where do you think you fall right now?
Probably like a 5. Kind of in the unsure area. Like I know I've done it before, so I know I can do it, but at the same time, it just seems really hard, and it's not the same situation.
Well, what made you say 5 rather than 2 or 3?
I know all the ways it's bad for me, and I don't want him to grow up thinking that it's okay to smoke. I don't want him to use any kind of, I don't want him to chew or anything like that. So I know I need to, especially before he gets old enough to understand what mommy's doing, but I just don't know if I can do it.
Okay. So it sounds like you have a lot of reasons why you'd like to quit. You have been successful quitting in the past, and right now you're just feeling a little bit hesitant about your ability to do it.
Yeah.
Where do you think we should go from here?
I don't know. I'd like some help. I just don't know what kind of help I need.
Sure. So, well, if you'd be interested, that's something I can definitely talk to you about. There are a lot of new options that can actually help people be way more successful in their attempt at quitting. There's different medications you can try.
I don't like medicine.
Okay. There's also a lot of support groups and classes that you can take where you have other people to go through it with you. And sometimes just having that support can be a big part of it, especially for people like you where smoking is such a stress reliever.
That sounds nice, but I'm not sure if I have the time for all that.
Sure. It feels like something that would take up a lot of time and maybe not fit into your life. I wonder if we could talk about some options that might fit into your life.
That would be really nice.
Okay. Well, if you're willing, then we could set up another appointment where you could come in and we could talk more about that.
I would like that. That would be great.
Great.
Thank you.
Sure.
You see, folks, how many things we learn now and we hear now when we learn the selective listening and hearing different statements from the client selectively. Do you see that almost in every sentence she said, there is both change talk and sustain talk? And over time, in the course of the conversation, because the physician now is very strategic in her reflecting, in her approach to this mom, in the course of the conversation, this lady, the patient, is giving more and more and more change talk, which is exactly what we want, because the more the client is talking about change, the more likely the change will happen. This is your homework assignment. There are 7 statements on your screen. And I would like you to, when tomorrow or anytime you want, try to read the statements and try to find out what is the change talk. In every statement, there is a piece of the change talk. Find it out and try to come up with the responses. Remember, what makes motivational interviewing directive is our ability first to hear and recognize the change talk. And secondly, to respond to change talk by reinforcing it, getting more of it. How can you do that? There are a couple of strategies that might be very helpful to you. One of them, actually, you did see in the last video. You may use something that we call it an importance ruler. And here's how it works. When you talk to a client, you ask a question, please help me understand it. On a scale 0 to 10, how important is it for you to make this change? By the way, this is one of the examples of a very good quality closed-ended question. This is a closed-ended question because you're limiting the options for answering. This is a very good and very important closed-ended question. So not every closed-ended question is bad. So you're asking a question on a scale 0 to 10 or 1 to 10, doesn't matter. How important is it for you to make this change? So 0 is not important at all. 10 is the most important thing in your life. Where do you think you are at? Just rate yourself. And the client tells you, well, I don't know, it's maybe about 4 or 5. Okay, whatever the person says is fine. But the next thing is, I'm asking, what made you rate yourself as a 5 rather than a 3? Please pay attention. I'm going down with my number. And then I will stop talking and I will start listening very carefully. Why? Because from this point further, now the client will start convincing me how important this change is for him or for her. So if the person says, well, this is not a very important, I would say probably about 1. Okay, what made you rate it as a 1 rather than a 0? It clearly is not too important, but still there's some importance in it. Why? Why it is not a 0? So you're going down. And this is one of the ways to increase the amount of change talk and to reinforce it, because now the client will convince you how important this change is for him or for her. At some point, you may ask a question, okay, what do you think might be helpful to you to move it from 5 to 6? And you're doing it in a very small increment. What do you think will help you to move it from 5 to 6? Folks, this is one of the differences between the traditional approach and the motivational interviewing approach. In traditional approach, if you ask the question, how important this change is for you on a scale 0 to 10, and the person says this is a 5, traditionally, most people would say, well, why is this a 5, not a 7? You see how this is something that you're ruining your life, and you said it's a 5. So now we're in a wrestling competition. This has nothing to do with therapy. But when you go a number down, or a couple of numbers down, that will actually give your client the opportunity to prove you or convince you that this is an important change for him or for her. Also, I would suggest you to remember there is a difference between importance and confidence. There might be something important for a person, but the person may not be confident at all that he or she can actually do it. If you ask a smoker, how important is it for you to quit smoking? And many of the smokers will tell you, oh, this is very important. I would say 8, maybe 9. But if you ask the same person, how confident are you that you can actually make it? Oh, I'm not confident at all. It will be probably 1 or 2. I've tried before and nothing worked for me. So you may apply the same ruler to importance and confidence. And the reason for doing that is to increase the amount of change talk you're getting. So you will get more pieces of gold, and there will be something more and more of something that you can work with using MI as a style. We can also use a decisional balance. This is the typical tool for cognitive behavioral therapy. By the way, one of the questions that I received in the email is, can CBT and MI be combined? Of course, these are very compatible treatment modalities. They are not the same, they're different. They're like two cousins. They're different, but they have a lot of fun together. They enjoy each other's company. Cognitive behavioral therapy gives you mostly the content of the conversation. The motivational interviewing gives you the style of the conversation. So that's why they're so complement to each other. In cognitive behavioral therapy, the decision balance is one of the typical tools. What are the pluses of changing? What are the minuses of changing? What are the pluses of not changing anything? What are the minuses of not changing anything? This could be done in a session. This decisional balance could be done in a session, or it can be done as a homework assignment. It depends on the context and many other factors. But this is a tool that is commonly used to increase the amount of change talk. Also, if you use decision balance as a cognitive behavioral tool that is actually very applicable to motivational interviewing, it might be helpful to do it, to ask the clients to write it down, not just talk about it, to write it down. And the reason is very simple. In addiction medicine, many of our clients, many of our patients, they tend to be quite impulsive. And their thinking pattern and the thinking process is very quick. And you want to work with somebody who is rational. So one of the ways to make your client a little bit more rational and calm down is ask the client to write things down, not just talk about it, but to write it down, simply because writing is slower than thinking or our speech. So by asking the person to write things down, you will slow the thinking process. That will automatically make the person less emotional and more rational. Okay. When we hear change talk, we can do a couple of things to reinforce. We may ask elaborating questions. Help me understand it. How do you think you can do that? Or in what ways do you think quitting drinking may help you in your life? Give me some examples from the past. How did you maintain sobriety, even for a couple of days? A couple of years ago, you said you were sober. How did you do that? You can use affirmations. We can definitely reflect, and we can make summaries. Now, let me tell you something about the summaries. You remember when we talked about the 4 fundamental skills in motivational interviewing, the ORs. We covered the open-ended questions. We talked about affirmations. Yesterday, we talked about reflections, different types of reflections. And we did not talk about the summaries. And the reason for me not to talk about the summaries is exactly because I wanted to first to talk to you about the change talk and sustain talk and the ways to recognize the two and respond, because it has directly to do with your ability and your way to make a summary. Here's what the summaries are. In motivational interviewing, I mean, the summary is actually a summary. That's what it is. You collect the material. Here is what you have. This is what we have discussed in the last couple of sessions. Or you can use the summary to make a link between the previous statements and the statements now. The last time you said this, and today we're discussing that. So let's make a connection between the two. You can make using the summaries, you can make a transition from one place to another. If you work with a client who is extremely talkative and you just can't stop this person from talking, one of the effective ways is by saying, hold on a second, let me summarize everything you said because this is very important. I really want to make sure that I'm not missing anything. So instead of but, let's use and. There is something very specific in motivational interviewing relevant to the summaries. We do not summarize everything. we summarize only the change talk. And it goes back again to our ability, our training, to selective listening to the client's statements, paying attention to everything that the person says, but making a decision what you will respond to and what you will not respond to. You really want to respond to the change talk to increase the amount of it, the intensity, and the frequency of the change talk. And you don't want to reinforce the sustained talk. So you will register it, but you don't respond to the sustained talk. So when we make summaries, we actually summarize only the change talk. Think about the metaphor here. Every time a client gives you a piece of change talk, it is like the client gives you a flower. So you take the flower, put it on your desk, and wait for more. In the course of your conversation, the client will give you some more change talk. So he or she will give you more flowers. You take the flower, put it on the desk. When you have enough flowers on your desk, you take it, put it together in the form of a bouquet, and give it back to the client. This is what the summaries are like in motivational interviewing context. We also may be able to increase the amount of change talk by another strategy that we call enquiring extremes. Should you decide not to change anything or to change something, what do you think the worst that can happen? Or imagine for a second that you succeeded in the change that you are thinking about or you're hesitant about. What are the good things that might happen to you? So you're probing two different extremes. What is the worst that can happen with change or without change? On what are the good things? This is quite similar to the decisional balance in cognitive behavioral therapy, but this time you can do it verbally. You can use a strategy looking back, looking forward. Looking back, what it was like when you did not use drugs for 2 weeks 5 years ago. What was life within these 2 weeks? What was life like for you? How did you feel? What was happening there? How did you do that? A client can tell you, well, you know what? The only time in my life when I was sober was 4 years ago. I met this girl, and we kind of connected. I liked her a lot, and she liked me, but she didn't like the way my drinking was going. So I didn't drink for 6 weeks. And then she left, and okay, how did you do that? For most people with your amount and history of drinking, that would be very difficult. How did you survive for 6 weeks not drinking at all? Because now I'm looking for the strength, not for the pathology. What the pathology is, we both know. It doesn't really make sense to continue talking about the pathology. What I'm interested is to find out what are the strengths that I can use now. When we utilize the ORS, the open-ended questions, affirmations, reflections, and summaries, when we increase the amount of change talk, if it's possible, gradually, we'll start seeing some signs in many patients, in many clients, we'll gradually start seeing some signs of readiness to actually to move on and to try to change something. You will see decreased defensiveness, decreased resistance. The client will start discussing more about the problem, less about the problem and more about the possibilities to solve the problem. You will hear more and more change talk. You will hear the client will start asking questions about change. So do you really think I need this treatment? Or tell me more what this treatment is like. And this could be the person who 15 minutes ago told you, I don't need any treatment. This is all crap, all BS. I don't need any treatment. Forget about it. 15 minutes later, the person is asking, okay, tell me more about this treatment. I really want to know what it is that you're talking about. So there will be some small signs of getting less defensive and more. You will hear more signs that the person is getting more ready to at least experiment with the change. It is happening in our clinical practice. It happens I've seen it all the time, many times. During the first or second interaction with the client, when the engagement is still not sufficient, the client is very tense, the relationship has not been established yet, counselors often ask the question, so what are your goals? What do you want to accomplish? So what are your plans? You remember, folks, the fundamental processes. Planning is impossible without sufficient engagement, without clear target behavior, and without evoking from the client the ideas or the thoughts what might be helpful. Planning is something that we really have to be very careful in terms of the timing. We have to be very careful when we start ask questions. So tell me, what are you going to do about it? Incidentally, let me tell you right away, this is one of the best, at least in my experience, one of the best clinical questions of all. When I work with an ambivalent client, and most of my clients are ambivalent, and people presented to me the whole story. Now we have some sufficient engagement. I think I know what the story is. One of the best questions for me is, okay, what are you going to do about it? And that actually can prompt a lot of conversations, and quite meaningful conversations. In the course of motivational interviewing strategy, when we start hearing more conversations about possible goal setting and possible planning, the conversations and statements from the client, not from me, it might make sense to reinforce it by reflecting. So it sounds to me like you have a pretty good plan. How are you going to lose weight, and how are you going to start exercising, or how are you going to quit drinking or reduce drug use? What do you think you might need to make it happen? So now we're discussing steps and available resources. It would be really nice if your client writes it down. Not you write down for the client, but the client writes it down in terms of, here's what I would like to accomplish. These are the resources that I have, and this is the way I will be doing it. So now the client is not just talking about the plans, but the client is talking about, here is what I will do. This is my commitment. I am not exercising yet, but tomorrow morning I will go and buy a pair of Nike shoes. Well, you see, there is a significant commitment here, because if I spend $50, $60 for a pair of Nike shoes and I don't exercise, I will really look stupid in my own eyes. So I made a commitment, I made an investment in my change. This is something that's absolutely worth appreciating and affirming. I just want to remind you the fundamental processes, which is extremely important, and these processes are not sequential. The first three, engaging, focusing, and evoking, is something that is circular. We do it all the time. This, as I said, this is like taking a shower. We do it every day, and we use these three processes with our clients every time we meet. And it may sound very scientific, but if you have skills, if you know what are you doing, it may take a couple of minutes to engage and re-engage the person, to decide what the target behavior will be today, and to elicit from the client the ideas and thoughts. It can be done really quickly. There is one thing that I really want to address you before we get to the questions. Something that I've heard before many times from many people, particularly at the beginning of their motivational interviewing training. The question is motivational interviewing a way to manipulate people into doing something they don't want to do? This is a reasonable question, and I would appreciate, and I do think that some of you might have this question right now in your mind. Historically, I myself and some of my colleagues, I know for sure, we have been offered quite significant amounts of money from the sales companies, car sales, pharmaceutical sales, to train their sales staff in motivational interviewing. So they will work with clients, their clients, in a way that will result likely to more profit. And if you have the experience of going to a car dealer buying a car, I mean, they do use some of the strategies that are resemble the motivational interviewing. When you go to a car dealer and the car dealer tells you, how important is it for you to have the car today? Or what can I do for you? How can I help? So you will drive this baby home in 2 hours. These are some of the tools, some of the skills that good salespeople use to, in fact, make me do things that I'm quite hesitant, quite ambivalent. In this case, in this example, this is a manipulation, and this has nothing to do with motivational interviewing. And the biggest difference is whose benefit is in the middle of the whole interaction. If we train motivational interviewing to car dealers or people who sell pharmaceutical products, we're doing it for their benefits. They will manipulate people into doing things that may or may not be beneficial for the clients. This has nothing to do with MI, and I have never agreed to train MI people from sales or even the law enforcement, police forces, because that could be used for manipulation purposes as well. So if you have a question, is motivational interviewing a way to manipulate people into doing something they don't want to do? The answer is a no. If what you're doing, you're doing it for the benefit of the client. If this is the benefit of the client, then in this case, this has nothing to do with manipulation. You're not manipulating people to do anything against their will. You're just assisting people to explore their ambivalence and to find the solution themselves, how to navigate through the ambivalence and get the result they want to get and get better with their life, and in our case, with their substance use problems. This is my email. If you have additional questions, now we're getting into questions. This is my email, and email me if you wish. If you want to communicate with me, I'm typically good in responding emails. I will try to find time to do that. And I think we can, there are a couple of things that I would like to address. I received a number of questions, actually quite a few questions from you via email. It happened this morning. It would be impossible for me to answer all of these questions right away, but I will address some of them because it seems like there are common themes in the questions. There is a number of questions relevant to my comment about sarcasm. And one of them is, let me read it. Is any chance of possibility of sarcasm even being a funding base for easy relationship to lightening mood and ease into conversation? So folks, let's distinguish sarcasm from humor. Humor is definitely one of the therapeutic tools, and if you use it properly, humor could be very helpful in treatment sessions, exactly to light the atmosphere, to just decompress a little bit, to help the client to decompress. But there is a major difference between the humor and sarcasm. The humor is your way of making the situation look funny. Sarcasm is your way to making the person look funny. You understand the difference? If you offer the client your humor with the idea to help the client to see the situation from a little bit funnier angle, that is perfectly fine, depending on the context. But what I don't want to do is to make the person look funny, because nobody likes that. So this is the major difference between sarcasm and humor. There was a number of questions about different clinical situations and clinical scenarios. How would you use reflections, and whether you will use reflections? It is very difficult for me to answer these questions because a lot of things depend on your context, your interaction with the client, what type of client you're working with, the level of engagement, the type of relationship that you have established. So it's really difficult to answer without knowing the specifics of the situation. There was a conversation about motivational interviewing applied or not applied to different personality types. I mean, there are some data suggesting that people with some type of personality disorders, particularly antisocial personality disorders, it would be very difficult to apply MI for this particular population because their ability to experience empathy is almost zero. For this population, this would be quite challenging using MI. But the good news is people who do have antisocial personality disorder, actually this is a very small population. They cause all the problems and they experience all the problems, but the population itself is very small. For other types of personalities, there's good evidence from the dialectical behavioral therapy that actually including MI and mindfulness and combining motivational interviewing, mindfulness, and cognitive behavioral therapy into dialectical behavioral therapy actually could be quite helpful for people with borderline personality disorder. So there is a good there is a number of good studies on that. So it's again, it's difficult to answer, but I think the personalities, different personalities of your clients must be taken into consideration. But in most cases, you can utilize the relational part of motivational interviewing with the total respect for autonomy, respect, unconditional regard for personal choices, even if you disagree with the choices, the ability to be empathetic. This is something that you probably can use across different personality types of your clients. Okay, we have 10-15 more minutes to entertain more questions, and I would love to do that. And before doing that, I just want to thank all of you, and I want to thank the ISSUP, the organizers, for making my life really easy, taking care of all of the technical issues with the webinars, something that is much above my head. I don't know technically how to do that, but they were extremely helpful in doing that. Thank you.
Yes, it's a good team that we've had behind the scenes. So thank you to all of the ISSUP staff. Thank you, Igor. We've had a lot of questions again, and I just want to say to everybody before I start going through them that just because of time constraints, we're not necessarily able to answer all of them. But Igor has very generously given you his direct email address. We also have a network on the ISSUP website, which is under the treatment topic, and people can go there and we can ask each other questions, and we'll also have any further resources featured in that network. So if people are looking for a little bit more sort of follow-up information, that would be a really good place to go. Some of these questions are quite specific, but they've come up a few times, Igor, so I'm going to ask those anyway.
Okay.
We've had a few questions around people that are really resistant to change or resistant to this type of counselling, and a couple of participants have asked to frame this in the context of their situation, which is in a low-income country. They're having around poverty, ignorance, low educational background, inability to pay attention. Those sort of things that are influencing the interaction.
You're breaking up, but I think I got the question. So what to do with people who are very defensive and resistant?
Well, yeah, and specifically from a low or middle income context where there may also be poverty issues, some educational level issues that these participants are talking about their sort of real situation with their clients.
You know, this is a good question. To answer this question, again, we need to look at the literature and the science. Actually, there is quite a lot of literature coming from middle and low-income countries on the effectiveness of motivational interviewing in a variety of different populations. And what all of the studies actually show pretty much the same thing, is that even in this environment, in these circumstances, the mutual respect and use of some of the motivational interviewing strategies actually is more effective than traditional do it or else approach, or convincing or trying to convince the person that what he or she is doing is wrong. Definitely you need to make some adjustments even to the language, because motivational interviewing is something that we use our language as an instrument. So and different languages, they sound differently, and the everything linguistically could be different. In those countries with a lot of poverty and a lot of social challenges and social problems, when you talk to people respectfully, and this is one of the fundamentals of any kind of counseling, and particularly in motivational interviewing, people will tell you what is it that they think they need to get help, and then you will work with them using MI strategies and the fundamental tools to see what is doable. At the same time, I really want to remind you what I have said day one. Motivational interviewing is just one of the strategies, one of many. This is not a solution for every problem. So this is why it would be nice, in addition to motivational interviewing, if you build some skills in other types of counseling, because this will increase your professional repertoire. So remember, MI is a very helpful counseling strategy, but not the only one. I don't hear you. I don't hear you.
Sorry, I turned off my microphone because of the feedback.
Yeah.
On that note about the different types of therapy that it is complementary with, we've had a couple of questions trying to understand the difference between motivational interviewing and more sort of traditional counselling. Another couple of questions around motivational enhancement therapy and solution-based brief therapy. And if you could sort of go back, I think, to your initial on what makes motivational interviewing unique. Sorry.
Okay, I got it. The motivational enhancement therapy is actually motivational interviewing plus feedback. That makes it actually shorter. If you look at the World Health Organization brief screening and brief intervention approach, SBIRT, this is actually screening, assessment, and motivational interviewing in the form of motivational enhancement therapy. So we use MI strategies. We provide people with the feedback about their drinking or drug use. So this is a short variation of motivational interviewing, and what makes it short is MI plus feedback. In terms of other strategies, as I said, MI is very compatible with many other treatment strategies. What makes a fundamental difference between motivational interviewing and other strategies? In most psychotherapies, if I'm the therapist, I'm the expert. I'm the one who will give prescriptions, who will make suggestions, who will make recommendations, who will tell the client what to do, and the expectation is that the client will follow through and will do it, and the client's life will get better. In some cases, that's exactly what happens. And for many conditions, this approach does work. But unfortunately or fortunately, in the area of substance use disorders or other problem areas where people are very ambivalent, giving people advice or telling people what to do typically results in zero impact. People don't like being told what to do. And this is the difference between MI and non-MI types of therapy. In MI, I'm not the expert. The client is the expert. The client has all of the expertise. I'm the GPS who is assisting, navigating the client to move through, to resolve the ambivalence through not fighting the river. Because if you fight the river, you will drown. You will swim with the river. And this way, the river is not damaged and you're alive. This is what the difference between MI and other types of therapy. And this is what makes MI both unique as a counseling style, more effective in ambivalent clients and very compatible with other types of treatment.
Thank you, Igor. A couple of points around the specifics of the interaction. So we had a few people ask about how to take notes and have that real connected face-to-face interaction with the client. And on that same note, how people in this current situation that might be wearing protective equipment or even be doing this online can keep that connection with their client.
In terms of the taking notes, again, there is no any clear recommendation. I don't take notes. When I talk to the client, I don't. I'm trying to memorize everything the person said and then write it down later. People have different styles. I'm not saying that my style is the right one or wrong one. You have to design your own style. My preference would be to give the full attention to the client during your 30, 40 minutes interaction and take notes later. In terms of the protective masks, well, the only difference is that you won't be able to see the facial expression the way you would have seen it without the mask, but you will hear the client's speech anyway. So even if you close your eyes and you're still listening to the client's speech, you will hear quite a lot of things. You remember the exercise with these things. You see, when you listen and you know what are you listening for, how many things we hear now better than before. So the listening is the key skill here. And seeing the facial expression or nonverbal language is definitely important, but in my mind, not the most important thing. I don't hear you. You need to...
We had a question about how to keep motivation levels high. So if the behavior starts to change and then perhaps plateaus or even reverts back, sort of how to keep that motivation going.
Using all of the tools that we discussed in the 4 webinars. You might have a client who is relapsing. One of the ways to do that, the client came to you and you found out, or the client told you, you know what, I think I'm hopeless. I didn't drink for a whole month, but yesterday I couldn't hold it anymore. So I had alcohol last night. It happens. Well, if you just rephrase what the person just said, that might help. You know, that's an interesting thing. You're capable of maintaining 30 days of remission. So in the last 31 days, you drank only 1 out of 30 days. That's a great accomplishment. That's really interesting. So what do you think we might do together to get back and to have another 30 days of sobriety? And then on the 31 day later, we'll see what will happen. So I'm just reframing and rephrasing what exactly happened. When the person came to you, the person is relapsing, it does not necessarily mean a disaster or failure of treatment. It depends on your perception and how do you present it to the client to change the client's perception. You just said that you're hopeless. I certainly appreciate your point of view. Do you mind if I share with you my point of view? Yes. Well, my point of view, actually, you're quite capable. You are capable, apparently, evidently, you're capable of not drinking for 30 days and drinking only 1 out of 31. That's an interesting accomplishment. You see what I'm doing? I'm reframing, and this is one of the MI tools that we discussed actually yesterday.
Okay, thank you, Igor. Unfortunately, our time has run out, but as I said, we will keep the conversation going in the network on the ISSUP page. And so all is left really for me to say thank you, Igor. It really, we've seen how well received that is. We have many comments that are coming in throughout to really show the participants appreciation. So from ISSUP, but also from all of our listeners, thank you ever so much. It really has been an excellent series. As we've said before, the recording of all of the webinars and the slides that Igor has been presenting and any resources that we've talked about will all be on the ISSUP website. The link to that will be emailed to you in follow-up and along with a participation certificate. We have a lot of these webinars happening, and the next one will be at this time next week, where we have Tom Brown, talking to us all about the rapidly changing composition of the world's drug supply. So we hope that you can join us. That's World Drug Day, next Friday, the 26th of June. So it's a great way to focus in on this subject on that day. And we thank you all for joining and sitting with us through the series. Thank you again, Igor. Goodbye, everybody.
Thank you all. Good luck in your journey through learning MI, and thank you all, and be safe.
Thanks.